Tobacco. Welcome to the Tobacco Online Policy Seminar, TOPS. Thank you for joining us today. I'm Dr. Monsra Kont, a postdoctoral researcher at the University of Oxford. TOPS is organized by Mike Pesco at the University of Missouri, C. Cheng at the Ohio State University, Michael Darden at Johns Hopkins University, Jamie Artman-Boyce at University of Massachusetts Amherst, and Justin White at Boston University. This seminar will be 1 hour with questions from the moderator and discussant. The audience may pose questions and comments in the Q&A panel, and the moderator will draw from these questions and comments in conversation with the presenter. Please review the guidelines on tobaccopolicy.org for acceptable questions. Please keep the questions professional and related to the research being discussed. Questions that meet the seminar series guidelines will be shared with the presenter afterwards, even if they are not read aloud. Your questions are very much appreciated. This presentation is being video recorded and will be made available along with presentation slides on the TOPS website, tobaccopolicy.org. We would like to take a moment to make a special announcement. A free webinar entitled Challenges Regulating the Tobacco Industry will be hosted by Johns Hopkins University from 12 to 1 p.m. on Friday, January 24th. This event is moderated by TOPS Executive Board member, Dr. Michael Darden. Please see the chat for more information and the registration URL. I will turn the presentation over to today's moderator, Jamie Artman-Boyce from the University of Massachusetts Amherst, to introduce our speaker.
Thanks so much, Monsra, and thanks all of you for being here today. Before we continue with today's seminar, we'd like to take a moment to recognize the winner of the Best TOPS presentation of 2024. This year's award goes to Nancy Rigotti for her outstanding presentation, Cytosine for Tobacco Cessation, Recent Studies and Next Steps for a New and Old Drug. Congratulations, Dr. Rigotti. If we were in person, I would shake your hand, but I wondered, since you are joining us, if you'd like to at least give us a wave.
Thank you so much. It's a great honor, and I very much enjoy these seminars.
Wonderful. Thank you so much, Nancy. And for anyone who's interested but missed that seminar, there's a link to the recording in the chat now. Thank you, Nancy, and congratulations. So today we continue our winter 2025 season with a single paper presentation by Dana Mowls Carroll entitled Very Low Nicotine Content Cigarettes in the Context of Non-Combusted Nicotine Products, Findings and Implications for Public Health Policy. This presentation was selected via a competitive review process by submission through the TOPS website. Dana Carroll, MD, MPH, is an epidemiologist and certified tobacco treatment specialist. She was recently awarded the Early Career Investigator Award from the National Institute on Minority Health and Health Disparities, as well as the Jarvik Russell Award, which is an Early Career Investigator Award from the Society for Research on Nicotine and Tobacco. Her program of research has evolved from mainly describing commercial tobacco use patterns and risk factors via large-scale epidemiologic studies to also addressing commercial tobacco use via clinical trials. Related to her TOPS presentation, she's interested in the impact of potential cigarette product standards and was a postdoctoral fellow and later a co-investigator with the Center for Evaluation of Nicotine in Cigarettes at the University of Minnesota. Dr. Dorothy Hatsukami, a professor of psychiatry and behavioral sciences at the University of Minnesota, is senior author of the studies and will answer select questions in the Q&A. Dr. Carroll, thanks so much for presenting for us today.
Great. Thank you so much for having me. And let me get my slides up. Okay. Hopefully this is showing well. Jamie, just let me know if that's not the case. So I am thrilled to be here today from snowy Minnesota. As mentioned, I am Dana Carroll, and I'm an associate professor in the School of Public Health. And I'm going to be talking to you today about very low nicotine content cigarettes, which is quite timely given the past couple weeks with the potential product standard being in the news. So here are my disclosures. This research that I'm presenting today was funded by the NIH, and there are no tobacco-related industry sources of funding. So nicotine, and why are we focusing on very low nicotine cigarettes? Nicotine is the primary psychoactive constituent of cigarette smoke and is responsible for smoking reinforcement and dependence. And this quote here, I thought really encapsulated the role of nicotine. It was by Philip Morris in 1972. The cigarette should be conceived not as a product, but as a package. The product is nicotine, and think of the cigarette pack as a storage container for a day's supply of nicotine. Won't read all of it, but I think that conveys the role of nicotine in smoking. So reducing nicotine in cigarettes is not a new idea, and around that it could potentially reduce the addictiveness and facilitate smoking cessation. Really, this idea came from Neil Benowitz and Jack Henningfield in the 1990s, and they published their thoughts in this commentary in the New England Journal of Medicine. And I actually learned from Jack that they decided to bring this up and think about this on a jog during a conference. So it means that conference breaks can prove to be fruitful. So today's research and the results that I'm going to be talking to you about have really come after a lot of milestones in the field. And I wanted to review those just in a nutshell as best as I could today so that I can catch some of you folks up to speed who might not be as familiar as others. So certainly the Family Smoking Prevention Tobacco Control Act of 2009, which provides the FDA the regulatory authority over tobacco products, was critical in ensuring the standard can progress, at least in the United States. And one of the stipulation in this act was that nicotine content in commercially available cigarettes could be reduced to low levels as long as that was non-zero for the protection of public health. And so since then, there have been numerous studies that have sought to answer this question: the what, the why, the how. Can nicotine be reduced in cigarettes for the protection of public health? And many of these studies have come out of the Center for Evaluation of Nicotine in Cigarettes, although there's certainly been others. For example, the Vermont T-Course has been a powerhouse in this area as well. And these studies have contributed to a strong evidence base that shows that if we reduce nicotine levels in cigarettes to very low, compared to our normal nicotine cigarettes on the marketplace, these low nicotine cigarettes can reduce cigarettes per day and facilitate smoking cessation. Results from the scenic studies helped us understand, so what level is it that we need to reduce nicotine in cigarettes? And the threshold of 0.4 milligrams of nicotine was shown to be most optimal, and that's in a 2015 study. Subsequently, there was a study that looked at a question: should nicotine be immediately reduced, for example, a set date, or gradually over time? And the results of that study showed that an immediate reduction in nicotine in cigarettes would be most optimal in terms of reducing biomarkers of exposure and harm among people who smoke. Although it doesn't show this in this slide, I do want to share that there's been several modeling studies that have really shown the potential groundbreaking impact of this standard. And in fact, there's a 2021 modeling study that showed, based on this evidence base and an expert panel that informed them, that if this standard were to be implemented, and importantly, all cigarettes commercially available in the United States would be very low nicotine. Up to 60% of people who smoke would quit within the first year, and an estimated 8.5 million tobacco-caused deaths would be averted by 2100. Now, time has passed since that modeling, and so there's been deaths not averted. That being said, the impacts of this standard are quite, very high potential. You may know that New Zealand moved forward for a bit with passing this policy, but then it was not fully, it wasn't fully passed. But that was a lot of buzz. That was exciting, and thinking about this policy being passed around the world. And most recently in the United States, there's been a lot of buzz in the news around the nicotine reduction standard moving to the next stage in rulemaking with the Office of Measurement and Budget, which it just cleared and means it's moving on to a notice of proposed rulemaking just this past week or two. And so there are several other steps in this rulemaking process, but this momentum is quite exciting for those that have been involved in these studies, and certainly the news has been picking up on this as well. So I will say, while experimentally strong and important for establishing the foundation for this potential policy, most of these prior studies provided strict instructions to participants to only smoke their assigned cigarette, which was either the normal nicotine content cigarettes or very low nicotine content cigarettes. We know that's not the real world. So there is a diversity of nicotine and tobacco products available to consumers. And so showing in this type of environment that a nicotine standard is still beneficial over the status quo of having a diverse amount of products is certainly an important research question that needs to be further addressed and has been looked at in some more of the recent studies. And in fact, one of those studies I'm going to talk to you about today is what has become coined the marketplace study. So this study, as you can see here, involved several folks from around the United States and was a pretty tremendous effort. It ended up being a 6-site clinical trial recruiting people who smoke and was published in 2024 in The Lancet. And this is the one I'm going to do a deeper dive on. So what was the objective of this study? Although you probably can glean where I'm going. It's really to examine the effects of that very low nicotine content cigarette, an attempt to mimic the nicotine standard, versus a normal nicotine content cigarette that you would find in the stores today, on smoking behavior and biomarkers of exposure in this experimental marketplace that we try to reflect the real world with non-combustible tobacco products. In other words, somebody might say, well, mimicking a nicotine standard reduce smoking when compared with the status quo diverse marketplace. And I think this is an important way to look at this question because often I have been asked, why not just let the marketplace and a variety of products available help people switch to less harmful products? If there's e-cigarettes, nicotine pouches, they'll gravitate to those products. And so I think this really sets us up to answer this question. So I'm just going to briefly go over the methods, and I have actually one more slide on the methods after this, and then we're going to take a pause to see if folks have any questions about the methodology or any of the past studies that I mentioned. So on your left, you can see the eligibility, nothing too surprising. What we tried to do is recruit the general population of people who smoke. They had to have stable mental, physical health. And importantly, we did allow other tobacco and nicotine product use because many smokers do not just smoke, but use other products. And so that's an important note on our eligibility. In total, there were 3 phases of this study that ran from 2018 to 2022. The first phase was really just baseline monitoring. So after they were consented, we essentially let them go back out into the real world, and they completed daily phone calls on their tobacco use. So we knew what their baseline use patterns were. So if, for example, they were also using an e-cigarette at baseline, we got that information as well. And this also showed us if they were compliant to using the daily phone call and could be further considered for the study. Phase 2 is where we exposed folks to our experimental marketplace. And I'll show this on the next slide. And essentially what this goal was to maintain access to their usual brand cigarette. So if they were in phase 1 smoking Marlboro Reds, in phase 2, they got access to our experimental marketplace that had their Marlboro Reds, but also a variety of other non-combusted tobacco products that reflect the non-combustible tobacco products in the real world. After 2 weeks of access to that, that is when we then randomized them. And so they were either randomized to very low nicotine spectrum cigarettes or normal nicotine spectrum cigarettes. They got access to the other tobacco products, and we continue to monitor them in their use behavior and biomarkers for 12 weeks. So the marketplace. To me, this was a really fun concept that I was able to work on as a postdoc, and actually was able to take a trip out to the recently passed Dr. Warren Bickel's lab to learn about his use of a marketplace in studies. And so as you see here, what we were trying to do, and this is actually a screenshot of the marketplace where participants would access on a laptop in the clinic or virtually. And they would be able to see the products that they had access to in this study. If this was phase 2, participants would click on the cigarettes, and it would they could purchase cigarettes with points. And I can talk to you a little bit about what those points look like in a minute. And if they purchase cigarettes, then they actually were provided their usual brand. And that was either if they were already in person or they came by for a curbside visit. And we actually gave them their cigarettes. If this was during the intervention period, those cigarettes were either the very low nicotine content cigarettes or the normal nicotine content cigarettes. They could also navigate to a page with the vaping devices and check those out. And you can see some of these other products. So just to try to be as brief as possible, the goal of this marketplace was to have products that had the greatest market share. So for the tobacco products, the vaping, the smokeless tobacco, and the nicotine pouches, we actually went out to sites at each retail outlets at each of the sites and had conversations with the retail locations, the vape shops, and to understand what was the highest market share of products. We did this every year and updated the marketplace. And so it became soon called the complicated marketplace, but it allowed us to evolve as the marketplace evolved in the real world, which I think is a huge asset of the study. For example, nicotine pouches were not at the time of the beginning of the study available at the sites, but then I believe about halfway through became available. And so we introduced those into the marketplace for participants to choose from. And as a quick comment on points, participants were provided points that reflected their baseline cigarette and other tobacco product use, with the idea that they could use those points to exchange for these products. So for example, if somebody was smoking about a pack a day, and that was it, they would get a certain amount of points. If somebody was smoking 2 packs a day, they would get double those points. And we also gave some additional points to each participant to allow for experimentation, which we expect to occur in the real world as well. And with that, I am going to pause for questions on the methodology.
Thank you so much, Dana, for that brilliant introduction. So audience members, if you have questions, please do share them via the Q&A function. But the first thing I'd like to do during this break is turn over to our discussant. So we're lucky today to be joined by Dr. Justin Byron as our discussant, who's an associate professor at the University of North Carolina School of Medicine. His research area is in advancing communication science and tobacco control, including addressing misperceptions about very low nicotine cigarettes. Dr. Byron, over to you.
Thank you. Yeah, excellent presentation so far, Dana. I think you really explained all the thought and hard work that went into designing the study. I guess one question I had based on what you presented so far was if IQOS was on the market during some of the time of the study in some of these locations and whether you all considered including that as one of the products.
Yeah, thank you. We certainly monitored it as part of our surveillance efforts, but it never entered, many of the retail outlets that our participants resided in. So we kept an eye toward the device, the heat not burn devices, but at the time of the study, it was not included for that reason. I think if that study was implemented today, it certainly would be.
Thank you.
Is that it from you, Justin, or is there anything else you'd like to ask at this point?
That's all I have for now.
Great. And Dana, we have one question from an audience member. One of the eligibility criteria was stable mental and physical health. Would you be able to share how that was assessed?
Yeah. So Participants came in and they completed a pretty extensive medical history. We do have licensed medical providers who review that history with us. And so that the idea was really if they had any comorbid, health conditions, they were stable. And, I think a big one that comes up a lot is high blood pressure. And so if we detected they were on they had high blood pressure, they were not eligible for the study.
Great. Thank you, Dana. And now I have two questions that have come in around the points in baseline tobacco use behavior. So how did you calculate the equivalence of e-liquid, snus, and pouches to the number of cigarettes smoked?
Yes, this is a really good question. I'll start off by saying that the point calculation was the same across, both arms. And so that's important to note in a clinical trial. We put a lot of thought into this. And so what we were able to do is actually try and find, the points were really all based on a cigarette unit. And so what we tried to do is make e-cigarette liquid based on the nicotine level equivalent on a cigarette basis and calculate the points that way. It is much more complicated than that. I'd be happy to share our math with you, but we did look at the literature and tried our best to convert these products to a similar unit of nicotine, and then based on that nicotine, provide points. But it certainly was more complicated than that. So for example, if somebody was doing, had for some reason at baseline, a piece of nicotine gum that was 2 milligrams a day, and then somebody had a piece of nicotine gum that was 4 milligrams a day, they would get more points based on the higher nicotine. I'll also say one of the things that we thought through was the challenge that the e-cigarette devices and the nicotine replacement therapy is just more expensive to buy into than a pack of cigarettes. And so if they did want to experiment or uptake those products, there was a single-use coupon to get that device. And then after that, it was getting the e-liquid or the pods for it. So again, that was on both arms, that option. But we did think that through a bit as well.
Great, thanks. And did participants know in advance that their baseline tobacco use behavior would determine how many points they would earn in the follow-up phases?
No, they
Okay.
did not.
Okay.
Yep. And we encourage truthful reporting and let them know that if they are using an e-cigarette, that won't make them ineligible. We just want to know their honest reporting during baseline so we can take that into consideration.
Great, thanks. And I'll ask one last question before we move on in the interest of time. So just a follow-up question on the point system. Was any consideration given to different forms of nicotine across different products? For example, nicotine salts versus free-base nicotine?
That's a good question. No, there was not. Yeah, I mean, so to clarify though, the devices were priced in our marketplace at a level that so for example, we had Juul and then we had Views and some others. Juul was more expensive than Views, so Juul was more expensive in our marketplace based on how much more expensive it was in the sites. So again, the relative difference of all these products was site specific and trying to be real world. But then the points that participants got did not take into account, at baseline, anything beyond nicotine level.
Thanks so much. That is a lot of complexity to be.
It is.
And we are excited to hear what you've found. So do go ahead.
Okay. All right. Great. Yeah. I expected those questions, so I hopefully provided some clarity. So what did we find? So cigarettes per day were our primary endpoint, and the blue is the low nicotine content condition, and the red is the normal nicotine content condition. And you see they're starting just quickly after they were exposed to the very low or normal nicotine cigarettes after phase 2, that we saw a difference that was significant towards the end of the study as well. And I think this slide already starts to answer whether the status quo tobacco marketplace with the diversity of tobacco products is sufficient for helping reduce smoking. And I think the answer looks like it's not the case compared to a nicotine standard. Urinary SEMA, this is a biomarker. I think that's one of the important things that we did in this study was not just look at use behaviors, but biomarkers of exposure and effect as well. And so SEMA is a biomarker for smoke exposure. It's a biomarker for acrylonitrile, which is a volatile organic compound. And you see similar relationship where the low nicotine content condition declined pretty quickly after randomization and sustained to the end of the study. We also looked at smoking abstinence, which is really, really helpful. That's the goal, right? To get folks to quit smoking. And you'll see that the very low nicotine content group, starting around the week 4 intervention, had a higher smoking abstinence that continued to the end of the study. I will also say that those who achieved abstinence, the majority, actually specifically 81% in the low nicotine group, were using alternative nicotine delivery systems. That actually includes all of the products, but if you looked at it, it's in large part driven by e-cigarette use. Okay, this is the last slide of the main results that I'll show you, and then we can pause. And so these are the patterns of use. Your low nicotine content group is on your left. The normal nicotine content group is on your right. And the blue line represents combusted tobacco use. The orange line is dual use. So those folks are going to be using, their study cigarette and one or more of the non-combusted products. And the green line is no use of combusted products. And that includes both use of only non-combusted products or no use of products at all. And so we see in the low nicotine content group, lower combusted tobacco use and higher dual use in the initial weeks. But in later weeks, non-use of combusted tobacco, which is that green line that starts to creep up there, increase in the low nicotine content condition. And that as well, dual use more closely started to resemble the levels in the normal nicotine content condition. So it was helpful to see these patterns that really correspond with the reduction in the biomarkers that we saw. I think another take home from this slide is a nicotine, trying to mimic a nicotine standard. It's not likely to be a silver bullet. So many folks continued smoking either exclusively or dual use. And so we can talk about the implications of that in a bit. And I have another pause for questions.
Wonderful. So first over to our discussant, Dr. Byron, to see if you have any questions at this point.
Yeah, just a little one. On the previous graph, you have what looks basically like an impressive line of the green line of people who have stopped using the combusted tobacco. And you note here that it's both people that have quit all tobacco and people that are maybe still using just e-cigarettes, right? Non-combusted. Do you happen to know how much of that proportion was each?
Yeah, I would, the answer is yes. Do I know it off the top of my head? No. I do think it was majority non-combusted tobacco product use versus no use at all.
Thank you.
Yeah.
Thanks. And we have 2 questions in the Q&A. So the first one is about what motivated participants to join this study. If they weren't necessarily interested in quitting smoking, was the sole motivation to obtain free products? And how might that affect generalizability of findings?
Yeah, that's a great question. So we did not pitch this as a smoking cessation study. Sometimes we do pitch studies like that because we're looking for folks that are interested in quitting. So we took, and actually a majority of participants were not interested in quitting smoking immediately. We did pitch this, incentives and the opportunity to try other tobacco products, but other than maybe an interest in research and interest in incentive, I can't speak beyond that. I will say we have looked at the generalizability of our participants compared to smokers, for example, in the US representative path study, and they can be quite strikingly similar with regard to sociodemographic variables. So that gives me some, satisfaction that, this wasn't US representative, but our smokers are not just a kind of unique batch of folks.
Great, thank you. And I'm aware you might be coming on to this, in which case you can save your answer. But did you look at, and if so, were there any differences in results for people who might have been interested in quitting smoking versus those not interested?
Yeah, I do not believe so, but I have Dorothy in the audience, so if she can see if we looked at that. So that would be a really interesting moderator analysis to see how those interested in quitting versus those that were not, moderated the impact of the conditions on the outcomes.
Great. Thank you. So next question, which I think you might have partly answered already, talking about the representativeness of your sample to what you saw in PATH, were you all at all concerned that requiring urine samples might bias the participant group? For example, might a cannabis user be concerned that his or her cannabis use might be noticed regardless of whether your test would catch it? They might be concerned it would.
Yeah, that's a good question. So we, again, our sample looked quite generalizable to what we typically see with smokers. And now I'm thinking, gosh, I should have had like a table 1 to show folks the descriptive characteristics. So I'll note that for next time. But, I don't think we had, certainly if somebody didn't want to provide a urine sample, they would have, not continued on the study. But I can't speak to that.
Thank you. And last question for this round, can you speak to compliance in the study? Do you have any sense of how many participants assigned to the VLNC group used NNCs anyways?
Yeah, that's a really good question. So just for some context, the prior study that looked at immediate and gradual reduction, if we looked in the immediate group, and that was a group that was assigned to low nicotine cigarettes and instructed to not use anything other than those products, the non-compliance, so the use of normal nicotine cigarettes, which they got out in the real world, was around twice as much as it was in this study. So there still was non-compliance. Now, if this standard were implemented, smokers could not go to commercial outlets to get cigarettes with normal nicotine cigarettes. And so I think it opens kind of a question of the illicit marketplace and whether which has been expressed as a concern. But it was halved in the study, and that's really to the availability of the non-combusted tobacco products, which reflects the real world. I think that could be further reduced in a scenario where health communications was provided, strongly encouraging smoking cessation, kind of getting to some of my implications. But I also think that the FDA's strategic plan to educate smokers about the continuum of risk with tobacco products and the importance of complete switching could also help further reduce the non-compliance that we have seen even in the most recent study here. And it was about 2 cigarettes per day in the very low nicotine content group.
Great, thank you so much. On to your next section.
Okay. Great. So some of the additional key questions that were asked as part of this effort was ones that I think really pertain to health equity. So will certain groups of people who smoke benefit less so than others? And I'll tell you in a second, but what we did is, at least with today's presentation, I'm focusing on age, educational attainment, and racial identity. And I think this photo here just puts into perspective why we are interested in moderation. So I think there are more and more studies looking at heterogeneity in effect, and that's because what works for some or all might not work for others. And so while we see a positive effect from the low nicotine cigarettes conditions across these studies, is that the case when we look within certain groups And for me, it's really an interest in looking in groups who have typically had the greatest burden due to smoking. And so ensuring that potentially if we need to find greater nudges so that they can catch up, making sure the benefits are positive, like we see in the overall study, for example. So I already shared this. It really provides a health equity lens. And we focused on really older age versus younger adults, as well as lower education. And that's because these two groups have had either stagnant or more slowly declining smoking prevalences. And then the other group that we focused on was those who have been racialized as Black in America. And that's really because, interestingly, though, despite having a either similar or lower smoking prevalence, persons who identify as Black were more likely to die due to smoking. And so we thought these would be 3 key groups to really focus on as part of these moderator analyses. Just wanted to mention that the methods that were conducted in the parent study that I just covered pertaining to statistical analyses were maintained for these moderator analyses. I will say too, and this comes up in review a lot, when do you know there is moderation? And so we take the approach looking at both point estimates between 2 groups. So for example, older and younger adults, looking at their outcomes, as well as doing the tests for interaction, knowing that if it's not 0.05 or less, that kind of arbitrary cut point that we like to call significant, but it's maybe around less than 0.1, that's a signal for us. So we're really just looking and exploring for moderation. So here's the results, and they're displayed just a little differently, just to try and make it easier to see across the moderators. So this is looking at the average difference in cigarettes per day between the low nicotine group versus the normal nicotine group at the end of the study, at the end of the 12 weeks, across the different moderator groups that we were interested in. And essentially what you see is a negative axis, vertical axis, which means that the low nicotine group resulted in significant reductions in cigarettes per day compared to the normal nicotine group for all the groups that we were interested in. And there was no evidence that the magnitude of effect was meaningfully different. We also looked at incident rate ratios of smoke-free days during the intervention period. And so the higher the rate, the better for the low nicotine versus the normal nicotine group. And for racial identity and educational attainment, there was no evidence to us based on really looking at these point estimates and the interaction test that there was moderation. But age did surface as a significant moderator. So the number of smoke-free days with the very low versus normal nicotine, while was in the right direction, so 2.27 in the low nicotine group compared to normal, it just wasn't as high as that in the younger age group. So it's the older age group are benefiting, just less so. This is that biomarker again, SEMA, and we did look at other biomarkers that, and so there is more that will come with this publication, but with SEMA, we also saw a similar result with the age group. So this is a geometric mean ratio. So basically, if we're going to say the low nicotine group is better, we want a lower ratio. And so as you see, those 55 and plus had a ratio that was actually no significantly different than 1, meaning there was no difference between the 2 groups. Whereas those that were younger had a significant reduction in SEMA at the end of the study. And that to us was just not these point estimates, but actually the interaction test was significant. And then lower education also rises to a concern with potentially having a signal for moderation. And so that the interaction test was not significant, but we looked at the point estimates here, and I think that the p-value was around 0.1 to 0.2. So again, for us, it really raised a potential concern that the lower education group, while in the right direction, they weren't achieving significant reductions in SEMA. So I think this slide here helps us understand why that is. And I actually included sex on this slide too, just in case folks are interested. That was not found to moderate any of the outcomes. So as you see in the gold brackets, those who are 55 plus age and lower education had about either 7 or 8% of those in the low nicotine group that had completely switched to non-combusted products or were not using any products at all. So that is actually quite lower than all of the other groups that you see here. And so the question is, you know, what could be going on in these groups that has resulted in them being less likely to be nudged off low nicotine cigarettes. And so this is really a slide of kind of post hoc analyses and trying to think about some of the implications of those findings. So again, age and potentially lower education are two groups that could be mindful of for moderation. The background of this is that the majority who quit low nicotine cigarettes did switch to actually an e-cigarette. And we saw that this occurred less so in those of older age and lower education. Actually, there's been some analyses that have shown that there's a stagnation in the older age smoking prevalence, and one contributor to that is being less likely to switch to non-combusted tobacco products. So we looked in post hoc analyses, and I tried to illustrate this with my clip art here. But essentially, on your left, what it shows is that the older age has more social influences, close friends who smoke cigarettes relative to e-cigarettes than the younger age and higher education group has. So in other words, perhaps social norms may impact low nicotine cigarette use in our study. One of the things that we cannot mimic in these studies is that all smokers would be subject to a low nicotine standard. So in other words, folks in our low nicotine group are taking home their products, they're around their peers who are smoking or using other tobacco products. And so that is the reality of some of the limitations of these studies. So shall this standard be implemented for all smokers? Perhaps the social norms would play less of a role, but I think the take home is for us that those of older age and lower educational attainment might need more support to quit low nicotine cigarettes. They are still benefiting compared to the normal nicotine cigarettes, just less so. And so maybe that is more tailored direct education on quitting and referral to smoking cessation resources. We'll come back to this in a minute. I also want to mention a study that I have been involved with David Mendez and Thuy Lee and Joe McLernan. And so this is a modeling study that we are hoping to get published shortly. And essentially what this slide shows, which I'll tell you why that is in a moment, that this policy will actually likely serve as a pro-health equity policy when we look at race groups and rural residing persons. So what we did is we modeled the impact by 24 different scenarios, some really conservative of the impact of the standard, some more in alignment with what we actually are seeing in the clinical trials, and looked at the deaths averted by 2,100. What we found for American Indian, Black, and rural people is that the proportion of deaths averted, of the total deaths averted, was larger than the proportion these folks represent in the population. It's kind of a lot of words, but essentially it's an outsized impact than what would be expected. And that's because for American Indian, Black, and rural people, they either have such low cessation rates or high initiation rates. And the standard would really help these folks potentially catch up with their counterparts. Certainly, we see deaths averted in the other groups, but it just stood out to us that the deaths averted in these three groups would be outsized for what you would expect. So that finding actually really corresponds with the most recent Surgeon General report released, I think, just in November of 2024. And that report concluded that reducing nicotine in cigarettes and other combusted tobacco products to minimally addictive or non-addictive levels should reduce tobacco use among population groups. Certainly, we believe that, and actually, because of the initiation and cessation rates in certain populations, it could have an outsized benefit. So to wrap this up with some conclusions and implications, if you haven't been listening, tune in now. So we showed through this study that a nicotine, in an effort to mimic a nicotine reduction standard, if implemented in a diverse marketplace, it's likely to reduce smoking and harmful exposures over the status quo diverse marketplace. There's some reason to believe that the older age group and the lower education groups may benefit less so, and so providing them with some extra attention during implementation of the standard is warranted. This is not a silver bullet, unfortunately. I don't think that will ever exist for tobacco control. Dual use and exclusive smoking, even with the low nicotine cigarettes, was still common. And so this really reflects that this standard, when implemented, should be implemented as part of a comprehensive plan that includes education on smoking cessation, access to medication, and surveillance after the implementation. Again, I will say that the other promising avenue aligns with the FDA's strategic plan, which is to educate consumers about the relative risks of tobacco products and complete switching. That was not done in this study. We only provided packaging to participants based on what they look like in the real world. And so providing health communications in a more formal way would certainly be warranted. And this is just one idea that aligns with the FDA. So I want to make several acknowledgements. I am presenting here, but this was a well-oiled machine. This particular study was led by Dorothy Hatsukami, and Dorothy and Eric Donnie were the PIs of Scenic. And certainly, as you see here, there were a lot of other folks and sites that contributed to this project. So I'm just thankful for the experience and being part of the team. And with that, we have time for all the additional questions that folks have.
Thank you so much, Dana. That was a fantastic presentation. It was great to hear about those results. I'll turn over to our discussant for a final time.
Hi, Dana. Again, excellent presentation. A lot of thought went into the study. One of the things I happened to notice when I saw your slides in advance, and this I think would be worth mentioning, right, is what are the potential implications for cannabis or alcohol use?
Yes, thanks, Justin. We actually have a postdoc, Dr. Emily Hackworth, who's working with Dorothy and I, who is looking at this very specific question. And I think it stems from a concern of substitution. So when we reduce nicotine in cigarettes, it's just going to give rise to unintended consequences in cannabis and alcohol use. And her findings of this most recent marketplace study show no concerning increases or no actually differences in cannabis and alcohol use in the low nicotine condition compared to the normal. This tracks with other studies. There was a study out of Vermont, the Vermont group, that looked at THC. So they looked at cannabis and alcohol, and they also found no concerning increases. And I believe actually it was no increases, but I'd have to look back at that paper. And we also found in some prior studies that without a marketplace, that, and this was a 20-week study that Dorothy had done, that the low nicotine group might give rise to 2 more days a year of cannabis use compared to the normal nicotine. So it's quite small, and I would say not concerning, but that doesn't mean we don't want to do surveillance. I will say also a prior study on alcohol, which we're looking into with the most recent marketplace, found that right after folks in the low nicotine group got their low nicotine cigarettes, there was a potential signal for increase in binge drinking that correspond with like nicotine withdrawal period. But then at the end of the study, there was no difference in alcohol over time. And so I think these are really important questions and important to monitor. With cannabis, we've certainly had a change in the legalization. And so, I think if further studies are conducted during this interim where the rulemaking is continuing, it will be important to continue to monitor cannabis as a unintended consequence. But the nutshell is we've looked at it, no concerning increases.
Thank you. I guess one other question, it's more of a hypothetical. All of this as good science is rooted in the idea of you kind of you only change one variable at a time, right? You give people low nicotine cigarettes or not. In reality, the tobacco industry is likely to change what they do in response to a new policy, right? They could easily change their prices. It's a very profitable product. Have you thought about what the tobacco industry is likely to do in the event of a VLNC policy and how that would affect the actual rates of smoking?
I would fathom that they would push non-combusted tobacco products even more. And so maybe that would actually further encourage smoking cessation and ultimate harm reduction, knowing that complete quitting of all tobacco products is ideal, but not all smokers have that goal or are interested in that goal. So, I would not be surprised that the industry just ramps up their efforts that they have been doing already to promote non-combusted tobacco products. I think the price question is interesting with coupons. I mean, certainly they could discount non-combusted tobacco products even more with coupons. Definitely an interesting question to know what the industry will do, shall the standard go forward.
And that's true too, right? They could make moves that would benefit public health, right? It's potentially possible some company, kind of like the electric car companies have gone with electric cars, and they said we're only going to make electric cars starting in 10 years. Tobacco companies might decide to stop making the harmful cigarettes that are not selling well. So thank you again, great presentation, and I'd love to leave time for other people's questions. Sure.
Yeah. And to me, I don't know if the industry was really interested in public health, they would just get rid of cigarettes. So while they might do things that do benefit public health, the bottom line is the dollar. So, but I think sometimes both are achieved.
Thanks so much, Justin. So we have time for maybe 1 or 2 more Q&As. Please keep them coming through the Q&A panel. But if we don't have a chance to get to all questions, or if you'd like to discuss with the speaker directly with mics enabled, you're very welcome to attend Top of the Tops immediately following this webinar. If interested, please copy the meeting URL posted in the chat now so that you'll be ready to join the live discussion once this webinar concludes. So Dana, another kind of speculative question right now. We wish you had a crystal ball. We know you don't. Do you believe that the US government has the ability to prevent the market from being flooded with illegal high nicotine cigarettes when they implement the low nicotine standard for cigarettes, thinking about their inability to prevent the e-cig market being dominated by unauthorized products currently?
Yeah, that is a very good question. I know it comes up a lot, and I think this is what we're hearing a lot in the news about this like explosion of an illicit marketplace. I'd be happy to talk with folks after this and hear their thoughts. There's definitely some really helpful papers out there that have been written by Kurt Rebsel and others. I think Dorothy's on that paper as well about what we can actually anticipate when it comes to the illicit to the illicit marketplace. I think to me, this is not like prohibition. Low nicotine cigarettes will still be available, although less appealing, but a variety of non-combusted tobacco products will. And if smokers want to shift over to that and they're available legally, that to me seems like a way to really kind of reduce our concern with the illicit market. But it is definitely, a concern. I think surveillance is important. The paper I mentioned talks about a track and trace system that could be implemented, kind of like how cannabis from like seed to sale, to ensure monitoring of the illicit marketplace. But most smokers do want to quit. I think that's also important. It's just hard to do it with legal products that are so addictive. And so I think that's also important to keep in mind, but would happy to share some papers because this is definitely an important concept to be concerned about.
Thank you. And probably our last question for today, given the time, but do keep them coming in the Q&A and we'll send them through afterwards. Do you have any thoughts on how brand identification might affect VLNC uptake, especially with older, long-time smokers?
If I'm following it, brand identity, so it would be helpful to know a little more context, but just to kind of talk out loud, all cigarette brands sold in the United States would be impacted. And so all of them would have now low nicotine cigarettes. I would be happy to hear more what the question is really getting at. I'm not following completely.
So I'm maybe making a guess here, and I apologize
Okay.
if I'm wrong, but the way that I interpret this is, let's say you're a Marlboro smoker and that's what you identify as. Do we think that people would continue using that same brand in VLNC form?
Yeah, that's a good question. I don't know if we have any empirical way to look at that, but yes, I think just in general, smokers will find that their cigarettes are unappealing and not fulfilling their helping with their nicotine withdrawal. So those that do continue low nicotine cigarettes, they would jump around to different brands. I'm not sure, but I would assume that, brand is not just due to nicotine, right? Nicotine's pretty similar among commercially available cigarettes, except for the low nicotine cigarettes that are available on the marketplace. And so there's a lot that goes into the blend of the tobacco, the marketing of the tobacco packs. And so we can only speculate.
Great. Thank you so much, Dana. I'm going to turn over to today's MC to lead us out.
We are out of time. However, if you still have burning questions or thoughts for Dr. Carroll, you can join us for Top of the Tops, an interactive group discussion. To join, please copy the Zoom meeting room URL posted in the chat and switch rooms with us once this event concludes. We'll leave the webinar room open for an extra minute after the end to give everyone a chance to copy the URL, which is bit.ly/topsmeeting, all lowercase. Thank you to our presenter, moderator, and discussant. Finally, thank you to the audience of 230 people for your participation. Have a top-notch weekend.